Okay. All right, is that better? Is that better? Can you hear me now? Yeah? All right, we're gonna go ahead and get started. Thank you. So welcome to our Accords Health Equity Seminar Series, Part 2. We wrapped up our earlier series on health equity, and there was so much interest that we decided to keep going with a focus on social determinants of health and how we address social determinants of health in both clinical and community settings. So we have a series of seminars coming up. So first, Dr. Guilionetta will be coming in a couple weeks to talk about advancing implementation science at the National Cancer Institute. That will be a really interesting implementation science focused, really broad topic. In April, we have a panel presentation from several clinicians on campus who will be talking about clinical interventions and strategies for addressing social determinants of health. We have a visitor from Toronto coming in at the end of April to talk about responding to adverse childhood experiences in the nurse-family partnership. And then still in the works is another presentation that will be later in May around addressing social determinants of health in community and multi-sectoral partnerships. And so that will be Arthur McFarlane and Don Neese coming to talk there. Next slide. And if you don't already know, our Colorado Pragmatic Research and Health Conference, or CopperCon, is open for registration and poster abstract submissions. Abstract submissions are due on March 16th, and you can access this information through coppercon.com or the Accords Education website. And the theme for this year is around planning for real-world impact. So if you're interested in stakeholder engagement, designing pragmatic research, frameworks and methods for working with your stakeholders to design interventions that will make a difference, please plan to attend. And it is free for anyone who is a Anschutz campus affiliate, faculty member, staff, or student. All right, so before I turn it over to Megan, who's our speaker today, I want to bring your attention to the sign-in sheets. Please do sign in. And fill out your evaluation at the end. And there's also some flyers wandering around about the CopperCon abstract submission as well. All right. So our first speaker for our Social Determinants of Health series is Dr. Megan Morris. You might know her as the director of the Qualitative and Mixed Methods Core at Accords. She is an assistant not depressor, no, no. Assistant professor in the Department of Family Medicine at our School of Medicine here. She's a qualitative methodological expert on multiple health services research studies and a mentor on many different K awards. She's worked across a multitude of clinical areas and is particularly interested in employing qualitative methodologies to engage key stakeholders in identifying and addressing disparities in care experienced by vulnerable populations. She works a lot with the disability community. In her own research, she aims to identify and address provider and organization level factors that contribute to healthcare disparities experienced by people with disabilities. So with that, Megan's going to give us an introduction to social determinants of health and how we address them in the healthcare setting.
Thank you all for being here today. So as was introduced, I'm a qualitative researcher, so I like stories. And the story of how I feel like I stumbled upon this area was that I was really interested in healthcare disparities experienced by individuals with disabilities. And as a young researcher, I decided, okay, I'm gonna, launch into, looking at this population in the healthcare setting and think about interventions. And I was sort of stopped in my tracks a bit because I realized for this population, we weren't consistently documenting it in the healthcare setting and in electronic medical records or health records. So that led me down a path on this sort of documentation question of how do we document. I've participated in studies around disability, but also other populations, done several studies around the LGBTQ populations and other sort of social determinants of health. So we'll get in some of those definitions, but sometimes I tell people, people ask me what I study, I'm like, oh, documentation. And I get the response of, oh, that's kind of boring. So hopefully it won't be too boring for you today, because it's actually so fundamental to so much work we do. You can't begin to address disparities in health and healthcare if you don't know who your population is. And so we're going to talk through that today.
Before you go any further, I just want to warn you that we have to be out of this room in time for the next class.
Okay. All right. So we will be efficient with our time. I am fine if you have questions along the way. Please, we can answer them. Okay. So what I'm going to talk about today is just go through briefly definitions of social determinants of health and other demographic characteristics, talk about why we collect the data, patients' attitudes towards collection and these questions, current status, and then recommendations, lessons learned. What we will not talk about today is which questions to use, because that could not only take the whole hour, that could take the whole next week to debate which questions we should be asking, okay? And there's lots of different, again, resources out there for that. We'll also not talk about using we'll not talk about interventions today, because as you saw, we have lots of talks in the upcoming months that will address that. So please come to those talks, okay? So really briefly, what are social determinants of health? So I just added one model here. This is from Healthy People 2020. It has these 5 domains. You can find models with 9 and 12 domains. Again, for simplicity today, I've stuck with this, this model. And really simply, social determinants of health is really thinking about the economic and social conditions that influence an individual's or a community's health, their quality of their health. So often, historically, we in the healthcare setting have really focused on ourselves and sort of, the care that patients receive when they are in sort of the domain of healthcare. But it's really growing rapidly, and it's a very hot topic, as I'm sure many of you know why you're here, is to think about, again, expanding that and look at the effects of these other domains on the quality of health of individuals and communities. So these are a little bit more about the domains. Again, we won't spend too much time here. So economic stability, which is probably one I think that gets talked a lot with employment, food insecurity, housing instability, and poverty. We also have education. We have social and community context. I see a lot of questions around social cohesion being considered to be asked in the healthcare setting. Again, health and healthcare, which we won't dwell on today. And then the neighborhood and built environment. Access to foods, crime and violence, environmental conditions, and then quality of housing, right? So I'd like to bring up other demographics. So these are other demographic categories, and this is also not an extensive list of these other demographics. Sometimes these do get included into conversations of discussion about social determinants of health. And so sometimes people lump them in with social determinants of health. Sometimes they keep it separately. I will be talking about these demographic characteristics for several reasons today, okay? So we have race, ethnicity, primary language, which is also nicknamed REAL data, sexual orientation, gender identity, which is nicknamed SOGI, and then disability status. And one of the main reasons I would like to make sure that we have these other demographics questions in this conversation is the issue of structural inequity. Sometimes you'll hear structural racism. But if we only focus on social determinants of health, we are ignoring the role of racism, sexism, homophobia, transphobia, and ableism in the social determinants of health. So for example, if you're working in a community that has historically experienced redlining, where they, there was policies really to force different groups, specific racial, ethnic, minority groups into certain neighborhoods, you need to know that history and understand the impact of that on that community for you to then be able to think about access to housing and the neighborhood, okay? So again, we need to think about the historical and societal discussions around social determinants of health in these populations, okay? And it's important that we don't downplay or ignore intersectionality between these. And then also, which we're gonna really spend time today, is thinking about how this historical and this structural inequity is really influencing how individuals might be responding to the questions we ask them. So again, there's this rise in collecting social determinants of health in the healthcare setting, all right? There's several reasons for this. Main of which is to identify patients and families who can benefit from the connection to community support services and other interventions. Again, we'll be talking a lot about this in future seminars as a part of this series. It can also be used to track health and healthcare outcomes, and then also look at the impact of social determinants of health on patients' health and healthcare outcomes. So there are lots of calls for collecting this data from national groups. I've just thrown a few up there. Again, we could spend really the whole time talking about all of the groups that have recommended collection, but the first two here on the left and in the middle are actually from the Joint Commission around, the first one is cultural competency, patient-centered care. Again, in that they talk about collection of the real data and also disability status. They did another one that came out in 2010. The middle one is around documentation of SDOH. And then the one on the right, which is race, ethnicity, language data, that is from the Institute of Medicine, now National Academies of Medicine. That was actually back in 2009 when they started making these recommendations. And then the bottom there, you see I pulled out section 4302 of the Affordable Care Act. Okay. You can't talk about collection of social determinants of health or these other demographic characteristics without discussion of electronic health records, EHRs, okay? So with the increase of adoption of EHRs and sort of, again, policies for encouraging healthcare organizations to adopt EHRs, there's been this sort of parallel conversation going on. And so this here on the left was published in 2014. The Institute of Medicine put together a committee. It's really kind of hard to see the title, but it's Capturing Social and Behavior Domains in Electronic Health Records. So again, that they talked about social and behavioral domains, the social determinants of health domains are in there, as well as race and ethnicity and SDOH. So they have two phases. The first phase in this first report was talking about what domains to collect, and then the second one is more kind of practicality, how to do this, and recommendations, okay? Who has heard of the HITECH Act? All right, a few of you. So there was, I won't go into too much of the history, but the HITECH Act was from Congress, and it was, again, to encourage healthcare organizations to adopt electronic medical records or health records, okay? There's 3 different stages, and what they were was if you as an organization had a electronic health record, EHR, that met those sort of guidelines for that stage, you would receive some financial incentives. And so it was, again, a lot of healthcare organizations were following this closely. And so in stage 2, they had requirements or kind of recommendations for documenting race and ethnicity. And then stage 3, they included SOGI and other health domains, okay? And then I added, just because this is a ongoing discussion, you'll see a lot of the references that I've shown you today. A lot of them are from 2019. So this is, again, very new and evolving. In December of last year, I participated as an expert in a CMS listening session, which was, again, working on CMS identifying what domains and which questions they were going to recommend / require that to be recorded in electronic health records. Okay, so what do patients think? We've talked about, again, there's all these policy recommendations and experts recommend it, but what do patients think about this? And so I'm going to go through, again, some of the literature we have in some of these different categories. This is by no means an exhaustive literature search of this. I've, again, put some references because they're, as you'll see, with the first area, there's actually a systematic review. So I can't go through all 18 studies, but for real data, so this is race, ethnicity, and language. Last year, they published a systematic review of 18 studies that looked at, again, patients, families, reactions, and opinions towards healthcare organizations collecting this information. And really kind of across these studies, what they found, which will be I'll tell you is a common theme across all these studies, is that actually the majority of patients believe it should be collected, and they support it. But they always have concerns about who has access to the questions and the answers and where it was going to be stored. I'm going to give you an example. This is one of the first studies. It's a little old now, 2007, but they did a survey of a telephone survey in California, because California was considering some state level policies around collection of real data. And so they did this telephone study to understand what patients thought about this. And 88% agreed that actually healthcare organizations should be collecting this data. But 17% were uncomfortable with reporting or disclosing their race and ethnicity, okay? And then for Hispanics or Latina populations, 36% reported they were uncomfortable reporting their English proficiency. So we'll talk a little bit later about maybe some strategies to address that. Okay. Patients' attitudes towards collection of SOGI data. So again, this is an area they've actually done a fair amount, like 5 studies about this, and they've done it in different types of environments. In a primary care, they also looked at an emergency department environment about, again, patients' attitudes towards collection of SOGI. And they found that across these studies, 76 to 78% of patients endorsed and said, yes, this should be collected. And this is, again, across populations who do and do not identify as part of the LGBTQ community. All right. It was interesting, in one of these studies, they actually found, they also surveyed the providers and what the providers thought. And 90% of the providers thought that 77% of the providers thought that their patients would refuse data collection. So what does that tell us? Is that providers perhaps are more uncomfortable with asking these questions than and think and sort of maybe project some of that uncomfortableness onto their patients. Okay. All right, social determinants of health. What do patients think about collection of social determinants of health? This too is a growing area, and you can this probably slide will be out of date in the next few months because research studies keep coming up. This study that I have here was just published in December of 2019, so very, very recent. But they found in this study, and again, more and more studies are finding that patients are okay with this information being collected and are okay with it being screened for this. A little bit less, 65% report that they're comfortable with it being documented and stored in their electronic health record, okay? So we have a little bit of this disconnect here, thinking about, okay, they want it screened, but let's talk about where it's being stored. And then last group I'll talk about is disability. This was a study that myself and colleagues did, and this is actually, I think, of all the groups that we've talked about, the areas, they have the highest rate of comfort with this information being collected, 88%. And then we see there that, again, despite this high level of comfort, there are still concerns about who's collecting the data and how the information was going to be used. And people had concerns about it being used to discriminate against them. Okay. All right, we're gonna move now on to, so okay, now we know the policies, what patients think. So how well are we doing this? All right. First, with our race and ethnicity data and language, there's actually just not a whole lot out there in literature that is reporting on this. And so this is one study I found, again, it's a little old. It's from 2004. And in this survey of hospital, only 56% reported that they were routinely collecting race and ethnicity. And really important that we keep hearing anecdotally over and over is that a lot of this data is obtained by staff observation. Okay, so staff observing and making assumptions or guessing what the individual's race and ethnicity is. Okay, and I assure you that's still happening today, unfortunately. This is, I'll talk a little bit about a study we did, but I just pulled out from that. We looked actually it's fall 2018. We saw here at UC Health in our primary care clinics, 63 clinics, that the completion rate for the race and ethnicity fields was about 78%. Okay. Yes.
Is it the policy at UC Health to ask patients directly, and do we know how closely that's adhered to?
I will get to that in a second because I have a pilot study that really kind of demonstrates some of the challenges with that data. But yes, it is the policy here at UC Health that we routinely collect this. Specifically, it's collected during the patient registration process. Okay. SOGI. The Health Resources and Services Administration, HRSA, they provide grants to some healthcare clinics, and they started requiring that the clinics that they support collect SOGI. And so they went back for two years, 2016 to 2018, to look at these, and there are a little over 1,300 clinics, and see how well they were doing, okay? And so they found that, again, they sort of mandated it, and there was an option in the, the provided resources, and an option in their electronic medical records to record this. And 77% of the records were missing sexual orientation, and 63% were missing gender identity. Social determinants of health. This too is a recent study looking at federally qualified health centers. This uses data from OCHIN, O-C-H-I-N, and they're based out of Oregon, but they are basically run the electronic health record for federally qualified health centers that decide to buy into. And so they sort of manage the EMR so that they, locally, if they don't have the IT resources to do that. So again, they reviewed 2 years of data because they have access to the whole EHR amongst these about 500 clinics. And they also provided tools to how to collect this information, and information to the clinics about why you should be collecting. And again, there's a field they use Epic to record this information. And after 2 years, they found only 2% of patients had a documented social determinants of health response, okay? And over half of those only response to one of the questions. They had, I think it was about 7 questions, okay? So unfortunately for us researchers in the room who are like, oh, it's being collected, great, I wanna do an intervention. You might need to step back and be like, okay, who exactly is actually being identified? And you might have some challenges of really only getting a small subset of the population that will be eligible for your intervention, okay? And they found that most likely it was documented by a medical assistant, okay? So how are we doing for disability? Fall of 2018, we were 10% here at UC Health. We did not have a policy around it. Again, there's federal actually requirements to do this, but so what I would like to move into now is actually a pilot project we did here at UC Health to actually increase data collection of disability status. And I think sort of the lessons learned from this project could be applied to a whole host of other demographics and social determinants of health type questions. So again, I'll get at some of the challenges that we ran into. So this again is just a case study we did here of collecting disability status at primary care clinics at UC Health. So what we did was we worked with UC Health and we decided for all of primary care clinics, so there's 63 in the health system, we'll roll out for all newly registering patients. It was a 6-week trial that we did. Oops, sorry. So we went in January and we trained what is called here at UC Health Patient Line. So Patient Line is centralized scheduling for UC Health. Many of the clinics are moving towards this. All of these primary care clinics in UC Health do this centralized patient registration, okay? So, for us, I'm like, okay, great. We just got to go to one place and train all of these people. And we developed some training materials. We went in and over the course of 3 days, we trained about 65, they call them agents, 30-minute instruction and discussion about collection of disability status. So we provided the in-person training. We provided them materials, including FAQs and responses to potential questions patients might have. We also, during this 6-week trial, we sent them a few email reminders to, again, remind them, because it was a new behavior, new habit they needed to form. We also gave them little paper tents to put on their desks to remind them. We discussed how to ask the questions, reasons why we were collecting the data, to again get them to buy in that they too are part of the healthcare team and an important member of the team to collect this data, and then how to respond if patients have questions about why we're collecting this data. Okay. We have learned more about Epic than I ever thought or really probably wanted to know. So Epic, which is our EHR here at UC Health, and they're taking over the world, so many places. They have a registration wizard. So it was the questions, we had to figure out like which page of the wizard that it would pop up. And so we had to train them to make sure they go to that page and fill out those questions. But we already had the fields available in Epic. which was fairly significant. So a member of our team on the healthcare system, UC Health side, they had requested that what's called a yield sign to be put next to the questions that alerts just a visual reminder to the staff, the agents to ask that question. It took us 9 months to get that yield sign in place. And it was like, ooh, it just popped up one day and we didn't realize it was gonna pop up that day. So again, it took us 9 months to get something into Epic. Yeah. So the question is, did we have hard stops to require the agents to complete them? And the reason, the answer is no. And the reason why was because the health system was really nervous about what was going to happen if we start asking patients. And if you put a hard stop in Epic, it is for everyone. So there are some clinics that are still registering their own patients, and we needed to make sure it worked first before we rolled it out to the entire health system. So really, you know, I'm going to give the broad overview of our results of our study. So again, we had 6 weeks of the trial. We had 3,600 new registering patients in that 6 weeks. Okay, so a lot of patients. From baseline, we looked several months before we started. We were about 9.5%, and woohoo, we increased to about 46% across these 6 weeks. We had 2 phases, which isn't really important to our conversation here, but we had a shorter set of questions and a longer set of questions. That's the difference between the 2 phases. And then we looked at our maintenance, and we found we had about 54% in 8 weeks following the trial of maintenance. And I just, again, this is a new policy, so new for them. Just as a reminder, they've been required it's been the policy for several years, many years, to record race and ethnicity, and that's about 78%. Yes. So the question is how we define disability. There are recommended questions. There's so phase 1, we went through their 6 recommended questions from HHS, and these are the questions that should be asked by healthcare organizations. And phase 2, we actually just asked a general, do you have a disability or question? So. And so this percentage rate, remember, it's not this percentage reporting a disability. Some of them we counted if it was recorded as no disability or decline. So you can see here we have a lovely increase over our weeks. Okay, so we were as a study team woohoo, we wish we could get up to that 78%, but again, it was a new policy, so we're really minimal intervention, and we're great. Patting ourselves on the back, and this is great. And then we decided to, as sort of a quality check, to actually listen to some of the calls. So we were able to listen to 112 of the calls. And we unfortunately found a fair amount of discrepancy. So you'll see at the top there, those are the call recordings. And then on the left is what's recorded in the Epic. So we could compare with what was recorded in the patient's chart with what we heard over the phone. And basically we had 48% agreement between the 2, okay? So 50% of the patients who reported a disability on the phone that we heard had either no disability or no response recorded in the electronic health records, okay? 22% of patients reported no disability, had a disability recorded. Okay, and then 43% of the time, nothing was recorded. The agent actually asked the questions, but they didn't record it in the record. And then 52% of the time, the agent did not ask the questions, the patient had a recorded disability or no disability recorded. Okay, one huge caveat to this, which is, again, something we had to learn, and it's something all of you need to think about, is that when it gets recorded into the EHR, whether it's disability or another, race and ethnicity language, you can't necessarily see who is actually recording that. So we were implementing something in patient registration. This does not mean then the patient didn't go to their appointment and then someone during that appointment, a medical assistant or the provider, actually filled in that field. So you need to think about, again, just word of caution, you don't know who is actually completing that field, or did they have the training to ask those questions, or were they observing and recording it? So in the 61 calls that we reviewed that, again, the patients were asked the questions, only one patient asked, like, why are you asking me this? So again, we felt pretty comfortable that patients were okay with these questions being asked. Important thing to consider, again, as researchers, like, oh, it's just like 4 questions, like no big deal. It actually is a really big deal for our healthcare partners. And so we had to look at actually the time that these questions took. And so phase 1, again, was a longer set of questions, so it took about a minute. Phase 2 was 18 seconds. You're like, okay, 18 seconds. That's fine, right? Well, if you think about that 18 seconds, remember there were 3,500 patients over 6 weeks. Roughly, this calculates to an additional 2.5 hours of work per week for that staff, okay? So and that was, we just had one question. So adding one question added 2.5 hours. And this was just newly registering patients. This is not all the patients who are calling in for follow-up appointments, okay? So again, really important to think about our stakeholders and how much time it's taking to ask these questions. It was interesting when we, again, observed the questions being asked, the agents deviated from the script prompt 56% of the time. There was 2 main deviations. One, them just rewording it. So again, we had this kind of tested perfect way to ask the question. Well, in real world, they were adapting it to kind of how they would like to ask it, or how they thought was appropriate to ask in the context of their phone conversation with the patient. But the other one, kind of main category, was them giving caveats. So they are making me ask this question. You really just don't have to ask it. So don't feel compelled to answer it, but I have to ask this question. So there was still, again, lots of discomfort with asking these questions. After, again, we thought, and they said the training was sufficient, but again, it's just this comfort, and this is something new for them and just something they're not used to asking. Okay, so now I'm going to move on to recommendations and lessons learned about collection. This is from the literature and also my experience of working in this area. So barriers to collection, you need to think about privacy. Where are you asking the questions? Because sometimes these questions are going to be asked, again, social determinants of health, other demographic questions, they'll be asked in the waiting room, okay? Where are we recording the questions in the EHR? Who is going to have access to all of those, the answers to those? There are some concerns people raise about the legality of collecting this information. Particularly, you're collecting about, their housing. Is it even legal for you as a healthcare system to be collecting data about these social factors? The short answer is yes, it is legal, but again, clinics and providers do have questions about this. And then staff concerns with comfort with asking, which we talked about. There's, again, patient barriers that do come up. For the most part, across really all of our different categories, they have bought into this data should be collected, but they want to know how the data is going to be used. And you need to think about, again, recording the data. You might have to consider recording the data multiple times. So someone's housing status might change over time. Just because they come in one visit and have stable housing, it doesn't mean 6, 9 months, a year later, that might be not accurate. And so you need to think about how often you're going to collect that data. And then finally, kind of the holy grail is how do you act upon the data, which will be future sessions. Really quickly, just highlighting the importance of self-report. Like I said, early data around race and ethnicity, people were guessing and recording it. This is a marginalized population already. they should own and have access, like own their own identity, and we should be allowing them that, that right to have their own identity and report that out. Always important to remember along with this, allow for no response, an other or I don't know option. You know, one of the things we actually, for the disability questions, a lot of the agents would say, well, they didn't report a disability, but you know, I think they're having memory problems. And so I just clicked memory disability because they're having difficulty, you know, remembering when I was talking to them. So really important that, again, this is self-report. For those who are peds, important to think about who you will be collecting it from. The child, are you talking about the child's social determinants of health? Or the parent? Maybe there's, you know, parents who have different levels of education, housing. So think about, again, it's a barrier of our electronic health records of having multiple spots to record this. And thinking about it, because it can get messy. You have, you know, maybe 3 different people you need to record it for, you know, 6 different questions, and you have to ask them over time. So it can get really complicated quickly. So increasing patients' comfort, again, with disclosing and it being recorded. So that 2007 study where they did that telephone survey, they actually tested some prompts that go before the questions. And they found that statements explaining why it's being collected significantly improved comfort with disclosing and being recorded. They tested a few different statements, and there was a statement that I think this is interesting, that the data would be used for staff training. So they tested other statements like, this will be used to improve your care. The statements that did better were, this is going to be used to improve care for our entire population. So again, I think an important finding there. So think about explaining to your patients why the data are being collected and how the data will be used. There's always this concern of, but I don't have my intervention yet. Can we even be collecting this data? If, you know, can I ask them, you know, about housing or food if I don't actually have the resources set up to connect them? Once I had in a focus group, a patient said, you know, if you ask me if I'm thirsty, you better be prepared with a glass of water. And so again, a lot of concerns about that. But what we've done is ask patients to say, you know, what if we don't know the intervention yet? Do you still want us to ask you that? And they say, yeah, you can ask us, as long as you tell us why you're collecting it. So if you're collecting it saying, we're gathering this information to really identify, you know, across our clinic for this study, that how many people need this type of support, so we can, again, make sure and build that intervention, they got it. They were okay with that answer. So thinking about your method for collection. So there are paper forms, so intake forms. There's patient portals. You can be asking in person over the phone with a registrar that I talked about, in a waiting room, or some of this data is collected in an exam room with a medical assistant or provider. And then as a research you know, study, you can ask it multiple places. So some benefits and challenges with each of these. So paper or patient portal, it's more anonymous. So people do, especially SOGI, they've said they're more comfortable disclosing in that type of method. And this is more efficient. And yeah, you have the patient complete it at home before they even come in. But it's really easy for the patients to skip over questions. And it does require a certain level of literacy. And the patients can't ask you questions about how they should respond. Asking the registration or front desk staff, this again is potentially more efficient than having your provider, your primary care provider, do it in an exam room. And what's really important, you can connect them to services earlier. So if you know before that patient is coming in, they have these you know, again, challenges with, you know, access to food or housing, or they need disability accommodations. It's great if we know that beforehand, so when they are there in the appointment, we can immediately connect them to services. But as you saw, we had less control of how the questions were being asked, and the staff might not be aware of why the information is being collected. Providers, it's great that they can integrate that data into the clinical care. And oftentimes, really across all of our domains, patients do feel more comfortable disclosing to their primary care provider. But our providers are really short on time. So that's the main barrier there. So you need to think about training your staff. Your staff need buy-in and be comfortable with the collection. You need to teach them about what language to use. You need to know how to answer questions that patients might have, and need to know the importance of why the data are being collected. And again, one of the things we enforced with the agents during registration is that they are an important part of the team. So those agents sit in an office building, south of here in Aurora. So they're a bit disconnected from our campus. And need to let them know that the patient has a right to self-identify. Again, some EHR challenges that I talked about. You might not know when the data are collected or who entered the data, and they could change over time. And patients should be allowed to update and change their responses. What we have learned from our experiences, but also across the country at different researchers, it's not a stick it in the EMR and it will just, people will start using it. That's just not the case. The quality of the data might be questionable, so think about when you're using some of those responses to those questions, think about how to check the quality of that data. And then I'll just throw out LOINC. Has anyone heard of LOINC? Yeah. So what LOINC is, so for EHRs, you have CPT codes, which are your procedure codes. You have ICD-10 codes, which are your diagnosis codes. Where do social determinants of health fit in? Doesn't fit into all of those. So LOINC is an international language for basically other data elements that fall outside of ICD-9 and CPT codes. So again, something as a researcher in this area, I never thought I needed to know, but it was, again, important for to be aware of this because, again, there's this international language, so they have standards about how this data should be coded and entered in to Epic or another electronic health record. Okay, so that is really it for, so on conclusions, I think, again, collection of this data is important and necessary, but you really need to make sure you have patient buy-in. It is not necessarily risk-free. Sometimes it's not consistently recorded, and there's some implementation challenges. But here are some resources. Again, the PowerPoint will be available after the presentation. So here's some resources, and then I will take questions. I don't know where this quote comes from. If someone knows, let me know. But if you're not counted, you don't count is sort of something I've always kept in my mind when doing this research. And it's been used by different communities, used with the census, but I think it's really important to think about when we think about collecting this data in the healthcare setting, right?
We have time for maybe 2 questions. Quick one.
I have a Zoom question.
Okay.
That says, in collaborative systems with social service providers, what data are you sharing or can you share?
Oh, share between?
Yes.
Between, so the question is, what data can you share between like a community organization and like a healthcare entity? So the short answer is I'm not entirely sure. I would ask that question for our sort of future again, the people who are really connecting with those services. But, thinking about being HIPAA compliant, you are going to need to make sure you are being HIPAA compliant and probably set up some sort of relationship with those outside agencies.
Anything else? Any other questions? Go for it. Yeah.
In the study that you did at UC Health, as well as through some of the other research that you were doing, my question is, once the data, since it's government mandated to collect it, and we've seen that everyone's not on it, that's a whole other conversation. But once that information is reported, so for example, at UC Health, the disability was reported, and in fact, the patient did have a disability, are there any mandates for them to now accommodate said disability? Or
Yeah.
what does it look like on the other side of the reporting
Yeah.
of the
Yeah, so I'll repeat for those who are on Zoom. So the question is, you know, there's these mandates for collecting this information, but are there any mandates on the other side of kind of meeting those accommodations where it's a disability or even, again, a social determinant of health, meeting that? And the short answer is no, there's not requirements generally, partly because, again, a lot of that data is showing you is from the last few years. We're still really in our infancy in this area. And so, you know, I wouldn't be surprised if there are some future, you know, requirements, but there's just not enough out there to know what the requirements should be.
We are out of time. We have to clear out for the next class, but thank you everybody for coming. Thanks to those